So in the letter that I co-wrote with P.J. Langhoff to Tom Ryan, who worked for then Attorney General Blumenthal, who's now a senator of Connecticut, and who brought action against the IVSA in 2008, which ended in nothing, no decisions, so to speak. We do outline that we track who's going to benefit, the profit motives, and all the rest of it. And I've got a very short slide about that. I don't want to get too political today because I don't think this is the forum, but clearly things have gone amok, and I think there are many threads that feed into this. But what we have now is a disease that absolutely disassembles the brain in a very efficient way. It takes the core brain, the reptilian brain, the Komodo brain, and just rips it apart. And as I said, with the scaffolding, one bit of scaffolding, bit by bit, is taken away, and pretty soon it's in a heap. So this was a slide courtesy of my friend Jordan Fisher Smith, who was in the movie Under Our Skin and was the park ranger. And he just went on Facebook. I asked him for a favor, and he did this. This is a little icon we have for the clinic. Yeah, I mean, this is impressive. And so I thank you, Jordan, for putting that together. So here's our theory on the current epidemic, and this is watered down, folks. So we have a confluence of reservoir, vector, and host. We have encroachment in wild areas where we don't have the predators to kill the vectors, which is a white-footed mouse, for example. We have mutations that are environmentally induced, quite honestly. We have a lot of companies making money doing genetic mutations where they can see what they're doing in the first generation. They cannot see what happens in the second generation, the third generation, fourth generation. And we're getting a confluence of all these things. And nobody has, I mean, everybody's playing God, with the genes and trying to get better crops, and it's a disaster. So bioengineering for profit, warfare. I mean, everyone knows, I think, that there's been tick drops over certain countries, and I think it was done in the U.S. I can't prove it, so I better not, I'll be in jail tomorrow probably. Now, and also patients stop talking the physicians stop talking to the patient or listening. So what's happening now with physicians is because the IDSA cabal absconded with this issue, blurred it, has written a bunch of junk science, meaningless articles, and are trying to generate another vaccine because their first one in 1999 failed miserably. In fact, there's a lawsuit as a result. It flared 250 people up. But physicians are afraid to talk about Lyme disease because they're intimidated. They don't have any, their thought leaders have lost their mission. They've abandoned. And so the well-meaning physician may say, okay, I'll treat you a little bit longer, and then they treat 8 weeks instead of 4 weeks or something like that, and the patient's not better, and they give up because they have no direction, nowhere to go, no outline, and it's very sad. So we have an absolute dearth of physicians who know how to do this. 30 or 40 years ago, Senator Bayh and Senator Dole in the U.S. Did a law that said that it's okay to patent a biologic entity if you're an institution or an individual, thinking that it would promote exchange of information, accelerate research, et cetera. Well, it did the opposite. People patent something, they didn't want to share it, they wanted to get rich, and so everything became very secretive, and it just was a disaster. It needs to be abolished. And of course, the people that make the guidelines, our friends at IDSA, they make criteria that fit their construct. So, only certain people fit because they want to fit. They're slow playing the epidemic. Some of them, so we got three kinds of physicians. Some absolutely know they're evil. Some think they know they're evil. And then some are just clueless and defend the IDSA just on blind faith, and they're stupid. And so we have insurance companies who love to practice medicine without a license. NHS, from what I can tell, practices medicine without a license. And patients are denied insurance. Now, it's an outrage because not everybody needs IV therapy for 15 months. They just don't. If you get the basics down, you can do a pretty good job. So, but it does take some training, and we have to have a situation where we're training dozens, if not scores of physicians at one time. As we evaluate the patient, steps in diagnosis and treatment, the evaluation period, stabilization period, which I've already referred to as several months, treatment, which is 12 months or so, healing process the next couple of years, and remission if all goes well. So to have quality in life, you must have quality of life. It's a thief devolving all of us to a more primitive and human state. I think you can see from the video that's quite true. She is certainly not an isolated case. And luckily she was able to improve. And I can't say that for everybody, but she was improved. She has her life back. So a concept here is that as we treat and we've stabilized the patient, the goal of treatment is the simultaneous reduction of infection. And at the same time, we're enhancing and embellishing the immunologic capital. In other words, clonal expression of key T cells, which are reflected in immunologic strength, and as time goes on, reflected in immunologic focus, with a much reduced infection load, so that it's more of a level playing field. So, again, the treatment of the infection load is highly complementary to immunologic strengthening. So as the load goes down, the immune system comes up and starts to get control, and you get it bit by bit, slowly, and then you build on that over time. Now, the person is going to, the trajectory of recovery is going to be much enhanced if oxidative stress is kept to a minimum. So that means we have to maintain good sleep, that we don't take on any elective projects. But life happens, right? So, but the point is, you do what you can. This is your healing period. This is your year to be treated and then start healing. Essential life functions, our little ELF, a little acronym I've had for a long time. Our little ELF, herself the ELF. So we start with this, and this is just our way of using acronyms to help us get through this. And then here's an important acronym, POEMS. And these are the criteria that have to be met before we'll start therapy. It has to improve to a manageable level. So pain has to be under control. We don't use narcotics. Pain has to be under control. We have to understand what kind of pain it is and what is the best choice. But that has to be under control, and there's a lot of pain with this illness. Others stands for social support. Nobody can be treated alone. If somebody's really impaired, they need somebody right by them. There's all sorts of metabolic, endocrine, and gut issues which need to be flushed out. Mood and psychiatric issues need to be stabilized, and then sleep is critical. So just a quick focus on pain. Inflammation actually occurs with pain, so you've got sensitization of nociceptive receptors, so everything lights up. And then pain is the immune system does not like pain. And people will come to me and I can handle the pain. I said, well, that's fine, but your immune system doesn't like it. And it's all about your immune system getting better. So we're going to treat your pain, not just to be nice, but I have a motive here. All right, this is our A fiber and our C fibers. This one's about 10 times faster than this one. This one is more of a chronic burning type pain. This is what mediates the neuropathic pain predominantly. This is more pressure around the joints, that sort of thing. It's the old adage of, having a thorn in your foot and hitting the other foot with a hammer. The thorn doesn't hurt anymore. It travels a lot faster. Okay. So POEMS, we have to have other people involved, social support. Endocrine is just trash. You can see where the thalamus, it's right in the middle of the storm here, at the bottom of the brain. And so it's critical. We've had patients almost go to an adrenal crisis or go into adrenal crisis. Sex hormone dysfunction, low messenger, LH, FSH, things like that. Has to be looked at very carefully. They're common finding. This axis gets trashed. It's very vascular, it's small. And it happens by direct inflammation, oxidative stress, and we don't get that nice feedback loop that we want. And this is the anterior pituitary, the posterior. Two hormones made in the hypothalamus rest in the posterior pituitary, the oxytocin, love hormone, ADH, which we commonly see diminished, resulting in excessive urination which at night, full bladder at night. So the key is if you get up at night to pass water, do you have a spastic bladder? Do you have urinary hesitancy, or do you have diabetes insipidus? In other words, do you fill your bladder up when you go to bed because you don't have the hormone to resorb water? It ends up in your bladder and it's screwing up your sleep. So it's not going to kill you, but it screws up your sleep. So we treat that. And then all there's 6 anterior pituitary-based hormones here, which you're familiar with, should be familiar with. POEMS, mood, failure of inhibition, startle, I think you all know this, anhedonia, no joy in life. You know, they say, I have no joy, and nothing excites me. Apathy, generalized anxiety. Think of the amygdala and think of not being able to process and understand and how stressful that is. If you hear something, it takes you a while to figure it out. Or if you see something, it doesn't register because there's mud on the track, if you will, getting up there. Emotional ability, all kinds of bipolar disorders. PANDAS is a childhood illness, I think, focused with a lot of OCD, focused in I think it's in the cingulate gyrus, and I think it's really an extension of these infections. Hallucinations, auditory and visual. So when patients have hallucinations, I talk them through it, and I ask, is it auditory, visual, or both? What's happening? And I base my treatment on one question: do they freak you out? And if they say, no, I can deal with it, that man over there doesn't really bother me, I don't treat. But if they freak them out, they're on an antipsychotic. So we have to stabilize. But that's my question, honestly. POEMS, sleep. Oh my gosh, sleep is so important. Everything from restless sleep to induced sleep apnea. So people that never had sleep apnea all of a sudden have a palate that's flaccid. So everything flops in the back, or they have a palate that's hyperactive. So they're choking on their, and so they develop sleep apnea, or they got restlessness because the limbic system is hyper-irritable and not inhibiting. I ask about dreaming, and again, we use drugs to get them into deep sleep. Vivid intrusive dreams are very common. I like lamotrigine for that. Sleep is very important. A fellow named Hastings, I think he's British, but I don't know if his work was done in the US or not. This is a beautiful model here showing the light factor and how it's a very complex pathway. And there's a new drug called Belsarmo actually inhibits a waking molecule called oxyrin. But anyway, pineal gland makes melatonin. In my experience, melatonin doesn't work all that much. I understand you can't get it here, it's a prescription or something, and which seems silly. But we'll try the herbal things first. We'll try valerian root, we'll try chamomile tea, melatonin, and so forth. So we'll try that first, and then we often end up on a benzodiazepine, which I know is scary to everybody, but if people can't get into sleep, you have to get them into sleep. And then the deep sleep drugs are something I will discuss. All right, all sorts of bad things happen when you don't sleep. All sorts of bad things, very bad. Immunologic, So we have some scientific research that shows we have effects on cellular repair and maintenance. We have all sorts of metabolic effects. It's just not a good thing. And certainly when you're diseased, you need that sleep. That's the only chance you have. Here we have the awake state, the light sleep, REM sleep is down here, and the delta sleep. And so it's interesting because the brain remains active in REM sleep with the body muscles. So when you're dreaming, you're supposed to be perfectly flaccid, right? So I have patients that when they're dreaming, they're riding the bike. And then the delta sleep, you can't really assess that in the patient. You can ask the patient if they dream or if they're vivid. That's a lighter area. The delta sleep, do you feel sleepy during the day? Do you feel, I slept 12 hours, yeah, but I needed a nap. I felt sleepy, absolutely sleepy the rest of the day. They're not getting delta sleep. And here we go. Now, most of the delta sleep happens in the first 4 hours. So if you can get a solid 4 hours of sleep, that's 80% of the game. So the delta sleep is down here. You see in the first hour, person went to bed at 11 o'clock, more deep delta sleep, a little bit less, and then hardly any in the rest of the evening. And meanwhile, our REM sleep wakes up, we start dreaming. You know how you dream just before you wake up? I love to dream. If I like to dream when I wake up, I go back and finish the dream. If I don't like to dream, I get up. Okay, this is the Nutritional Academy. I'm not going to get into this a lot, but the gut is very important, and I have a little cocktail I use for gut health, which we can talk about. Antibiotics. Why do we use antibiotics? People say antibiotics are bad. It's a tool. Antibiotics are just a tool. You see, this is a complex affair, and we do a lot more than antibiotics. We are not an antibiotic factory. We try to use them intelligently, but the point is, when you're in extreme oxidative stress and can't get out, you need to level the playing field. So we need antibiotics to level the playing field. They will reduce the spirochetal load. We still need the immune system, which is not helping yet, but it will help more in time. And if we use antibiotics, we don't say, do what you want, the antibiotics take care of it, not at all, it's just part. All the arrows have to be pointing in the same direction in these patients, okay? We can't have two arrows going this way. Everything has to be going the same direction or we're going to have a stop and start result. We try to limit antimicrobials as much as we possibly can. We don't really have a way to identify or target, but we know there are multiple strains. I think most of them are probably sensitive. Synergizing co-infections I mentioned, we have to treat more than one infection. We know how sneaky they are, so we have to have a strategy. So I'll periodically use a metronidazole in the cycle to kill the cyst form. We call that, so if we don't kill the spirochete, the wild type, it'll go to a cyst form, we kill the cyst form. So that's in the pulse therapy. Combination therapy limits resistance. And we have learned over time what combinations use. We don't use the harsher drugs early on, we do not. We save those for later, but patients will learn to accommodate harsher drugs. And when we start, we just want to get a pruning process going on. And I'm going to move up here to a metaphor. So I used to fancy myself an arborist. I really like working with trees. So let's say our mighty oak is ourself, and this is wintertime. And they have infirmities, structural, a lot of disease branches need pruning. Scale, just loaded with insects, Lacunium fungus, got crown fungus here with hypopenon, and they got some root girding and things like that. So what we do in the winter, or when our patient first comes in, is we make assessment, prioritize changes. So we do very gentle pruning of the diseased branches to start with, and in our patient, we do our evaluation, we get them gluten-free, we talk about detox, where the salt bath, the sauna, light exercise is tolerated. We get the lab outliers. There's many commonly abnormal. We address those, replete those. We address pain, whether it's C fiber or musculoskeletal A fiber. We use combination neurotropics like lamotrigine, gabapentin, pregabalin, and there are 3 or 4 others that we use. If someone has regional pain, which is don't touch me pain, which is the worst pain of all, we'll use Marinol or THC. Occasionally cannabinoids work, but they're much better for seizures and anxiety. That's a cannabis oil that I think you can get here. So we see a ton of Hashimoto's. It's not a big deal. If you're looking at thyroid function, this is really the only critical value is free T3. We look very carefully at adrenal disorders. Now we see a lot of inversion of adrenal disorders so that the cortisol may be low in the morning and it's high at night. I made the mistake of treating that, and you simply ask the patient, do you rev up at night? Is that when you're busy? Yeah. About 11 o'clock I wake up and I start revving. So they've inverted their adrenal cycle, so you do not treat them in the morning. Phosphatidylserine and maybe low-dose naltrexone may be helpful there. Mood. We're very comfortable with psychotropics, and patients want them. We need to stabilize this poor brain to the extent possible without, and very carefully, one step at a time. And sleep. We employ drugs like trazodone and Seroquel for the deep sleep. Gabapentin actually has activity for deep sleep, and so does pregabalin. So sometimes if you're lucky and it's not too bad, somebody's restless and they're not getting deep sleep because they're restless. So if you're kicking all night, you're not getting the deep sleep, okay? If you have sleep apnea, you're not getting deep sleep. So sometimes you can get it done with one drug if you're lucky, but oftentimes you have to use one of these products. After stabilization, remember we're still in wintertime with gentle pruning. We give very simple antibiotics like cefuroxime, long-acting tetracycline, azithromycin, maybe Monday, Wednesday, Friday, 2 weeks on, off, add metronidazole to kill the cysts. So if we don't kill the spirochete, we're stressing it and push it to a cyst form, we pop the cyst at the end. So we just want compliance here. We want a little die-off, and we want to make adjustments to our program. So if we induced a new symptom, we need to address it or made something worse. Okay, here comes spring. Things are starting to look better. We started to do soil amendments. We're going to treat the infections down here. We've got scale spray going on. We've got antifungal. These are all metaphors for all the different things we bring in to our patients. And, you know, patients are taking like 6 to 8 drugs and all kinds of weird chemicals and things, and we do their liver and blood counts, and they're perfect, you know. And it's not a budge, it's a bring it on. So the second program, we get into Babesia, which is, I think, the key pathogen here. Is prioritized as the key. I think it's the engine for this illness, quite honestly. So we use combination antimalarial therapy. In the old days, when I first, 15 years ago, people were using Zithromax and Mepron. That's a horrible, ineffective combination. You need 2 antimalarials, probably 3. So atovaquone from this class, that's Mepron, or Malarone, an Artemisia product, such as artemisinin or Tethinur, Annula, which is Elecampane, and Coar, which is a combination product with artemether and lumatraxine. I use that as a booster. So we base the amount of treatment on the life cycle. Remember I told you about the biofilm. We're bringing in biofilm now because we know Babesia is in biofilm. If you don't bring in biofilm, after the first cycle I ramp up biofilm. So if we don't do that, we're going to end up retreating Babesia 6 months later or a year later. Blue Sky Days, Choline. So this is really the turning point in most patients. When the Babesia load goes down, and contrary-wise, if patients relapse with Babesia, or if they relapse, Babesia is far and away the #1 reason, reactivation. So you start to see traction, and now the tree of life in our metaphor becomes unburdened. Much treatment remains, and a lot of healing remains. So we still have strengthening to do. We still have root disease to deal with. Everything's much better. The crown is cleaning up very nicely, and now we're going to take care of any opportunistic infections, and we're going to continue to do soil analysis. That could be genetic testing. So the third cycle is a pyrimethamine-based program, which is an antifoliate product. We use it with sulfur or dapsone, it's sulfone if they can't take sulfa. And it kills the proteomyxoma, but it also probably kills some opportunistic parasites in the gut. And it's another way to break down biofilm, because the antiparasitics can actually get into the biofilm and can kill without the need of replication by the protozoa. And the same thing is true for fungi, but not for bacterium. So we're always finding enlarged livers and spleens by palpation in our patient population. And after they go through the Babesia problem, they pop back to normal. It's pretty cool. And I'll continue to treat. If I still feel it's a liver, I have to keep treating. And we always ask the patient, did you take stevia by accident? Did you screw this up somehow? Are you doing everything? And we just keep after it. But ordinarily, if we get 3 cycles with a full dose lactoferrin and xylitol, which we gradually increase by the 3rd cycle, if we do that, I feel very comfortable we're going to eradicate this very important co-infection. So people talk about sweating, night sweats. Well, remember you got dysautonomia. So by that point, if somebody's having heavy sweats, it's no longer the Babesia, it's dysautonomia. The autonomic nervous system and other systems are trying to reboot, if you will. So what are some clinical signs? If the patient doesn't do well on the holiday weeks, remember they've got a couple weeks off. If they're not sustaining, then we've missed something, maybe a persistent leaky gut absorption. We check what else is going on in your life. Maybe they got a gallbladder that's flaring up. Maybe got an abscessed tooth. Anyway, we look for that. And we also have found a phenomenon that's important in my model. I wouldn't see it anywhere else because we give breaks. We see in about a third of cases, we see what I call immune reconstitution. This happened in AIDS, where as the immune system got better, people started getting abscesses and things, and it was full of cryptococcus, or weird organisms. And it was there, but it was no immune response. So what we're seeing here is immune reconstitution and the reemergence of new symptoms, especially arthralgia. So we get rid of the neurocognitive stuff, and all of a sudden their joints are hurting like crazy. And I know Armin is a big believer in mycoplasma and chlamydia, and I absolutely believe mycoplasma and chlamydia are responsible. So now we have immune surveillance, which is now kicking in, creating new symptoms. We reassure the patient. The best drugs are minicin and rifabutin. Clindamycin and Zithromax work as well. And we use that in the off weeks, and we do that for several cycles, and that tends to take care of the problem. The little boogers are hard to kill, the mycoplasma and chlamydia. So we just keep pounding it. So after 12 to 15 months of therapy, less than 10 days a month, you can go to maintenance, which is 3 days a month. And now the tree of life is looking pretty good. Got acorns. And the mighty oak has been mended, nourished, and will sprout vibrant new growth. So it's a very happy situation. Oxidative stress, look at all this stuff. Comorbidities, spirochete load. This is a very stressed out person. There's no way they can get back to normal with exercise or eating gluten-free, but as we get rid of some of these things, the gauge goes back towards normal. And if you're here, a lot of people are here, and if they get rid of a few things, they do more exercise, get extra sleep, they can actually feel fairly normal, if you get my point. People in the deep red need help, big help, and they get better and better and better, and so we keep them there. All right, we have a healthy flight pattern here. This is another metaphor, if you will. We have free radicals, they're getting sick, they're flying down here. The balloon would really like to clear those peaks. And here it comes. We spared no expense. All right, so this one is in trouble here. All right, so we've got a detox. Get rid of those free radicals or else could be trouble. Oh, trouble. Let's try it again. Let's try it again. Let's try it again. I guess we're stuck. No, there you go. All right, you detoxed. You had a good flush. You exercised. Yay. Okay. Now this is all about microflora. I'm not going to talk about that because we can do it during the break. This is about methyl groups, which I know we're running late, but we pay a lot of attention to these. Most people know about this. This is our, we did this graph ourselves. These are all cycles that interact or interrelate. And so we have a methionine cycle, which I'll show you, the folate cycle 1 and 2. And this is where your MTHFR is, but more importantly, our BHMT. The noted CBS mutation is here. That's a very important one in terms of creating ammonia, which is a nasty toxin that we've identified. We can tell whether a patient has an MOA inhibitor, whether they're going to do well with, so it makes sense. So some people just can't take SSRIs, and this is why they can't get rid of the serotonin. They have genetic, sometimes, especially if it's homozygous. So here's another couple of cycles, so 4 and 5. So we use this extensively with patients, and it's becoming quite routine, quite honestly. So this is our mitochondria, is very important. Here's our cytochrome complexes, 1, 2, 3, 4. We're spitting out protons here, trying to generate a charge, and basically passing electrons here through the ubiquinol. And the electron transport here takes oxygen and converts it to water with the protons that it's donating. However, not everything is perfect, so sometimes the transport system almost always has free radicals. So therefore, it depends on SOD to break down the free radical to hydrogen peroxide. At that point, it needs catalase and glutathione peroxidase to help bring the peroxide, which is still toxic, to water. If these are deficient along here, you're not going to have enough charge to make that energy. So here's a few things that we've done over the years, and so the short list. We've coined the name Berlioz complex. We have consistently used, and I don't know why people don't do this, combination neurotropics to control C-fiber pain. It works very well. I don't know why people don't do this. We talked about, from the get-go, stabilization of light functions, limbic excitation, POEMs. There's a lot of work that needs to be done here, but we've recognized for a long time that there are deficiencies almost like HIV. CD4 counts are low, CD8. Immunoglobulins are low as well, and Judy can speak about that. I recognize the arthritic syndrome, which I just mentioned to you. Biofilm eradication, using xylitol and lactoferrin. I know that SAPI is using stevia, and I could probably use stevia. It's just a matter of me becoming comfortable with it. We have identified ammonia as a major culprit, nitric oxide and other things, and we look at those very carefully in our patients that aren't proceeding. We've always used combination anti-infective programs for Borrelia and co-infections. You can't treat Babesia with one drug. In childhood, we haven't talked about this, but in the child, what are the harbingers of illness in a child? We've identified certain things that have not been published, one of which is sleepwalking, which does is limbic excitation, bedwetting, and then certainly more obvious things like recurrent joint swelling, and then also prepubertal headache, especially in males. We think those are harbingers of trouble ahead for the adolescent and young adult. Now, what's really, really important here is, are we just talking about Lyme disease, or are we talking about other things too? We're talking about the whole big picture. Whole big picture. Do you know that of the, not excluding cardiovascular disease, cardiopulmonary disease, do you know of the top 20 illnesses, we know the cause of 2. We know the etiology. We know H. pylori for gastritis, and we know HIV. We don't know anything about Crohn. Who knows? What's the etiology of Crohn's? Anybody know? How about rheumatoid? How about any of the neurodegenerative disorders? Anybody know? We think that these rascals cause so much chaos they either directly or indirectly help expression in the genetically predisposed individual. And so, and we've seen people, I've seen smooth muscle antibodies in chronic hepatitis or autoimmune hepatitis revert to normal. I've seen SED rates go to normal. I've seen connective tissue diseases melt away. I've seen people get off prednisone. This is not new. It's just we're in a for-profit world, and it's really a shame because, so this is I'm going to end up here. So I like to do facts and hypotheses, and just kind of walk through this as we wind up. Borrelia is a genetically endowed higher order bacterium. We've shown that. Multiple life forms, we've shown that. Multiple species, we showed that. Hypotheses: human genetic immunologic risk factors for disease expression play a role in susceptibility and expression of this illness. Fact: Borrelia is often associated with other tick-borne pathogens in the Lyme picture, therefore complex. Hypotheses: there's a pandemic of this disease as a result of folding in of persistent pathogens in combination with Borrelia, with a dramatic effect of more profound clinical expression of chronic illness and more immunosuppression. Fact: BB has nefarious and very broad tropisms, capable of infecting multiple cell lines, fibroblasts, immunologic T cell lines, anything gets into endothelial cells. Other pathogens do the same, like Bartonella and Mycoplasma. Hypothesis: tropism by various species and other may play a role in strain-specific illness. If we could identify the strain, we might say, oh, this one does more joint pain, or this one does this, or this one's more serious. We don't know. We're clueless. Hypotheses: Borrelia and other pathogens have hijacked the human biome, creating chaos with their devastating tropism and having an inexorable immunosuppressive effect. Disrupting was what once was a peaceful symbiotic relationship in our body between 500 trillion microorganisms, 50 trillion cells in the human body. We used to all get along. And things have changed. There's a new sheriff in town, and we're not going to evolve. We're not going to do that. It's not in the cards. So again, I said this before, the human body biome has never had to contend with this stuff. The combination of virulence, persistence, survivability, with a marked avidity for critical neuronal structures, places the human biome at high risk for severe limitations in human capacity and normal relationships. And here we have an expanding and contracting universe, and there's a red dot, that's the Milky Way. Thank you.